Hello, everyone. Thank you so much for joining us from different parts of the world. My name is Farhad Zikria, and I'm joining you today from the United States. I serve as the Director of Operations with the TORC Global Education and Training Committee. On behalf of the Operating Room Global and the TORC Global Education and Training Committee, I'm delighted to welcome you to today's global webinar. We're pleased to have a truly multidisciplinary audience with us today, including surgeons, anesthesia providers, nurses, surgical technologists, educators, researchers, and students, and also healthcare leaders. We're currently joined by participants from multiple countries across different time zones, and we sincerely appreciate your time and commitment to continuous learning. Whether you're joining us from Africa, Europe, Asia, the Middle East, or America, you are very welcome. We strongly encourage active participation throughout this session. Please use the chat box to introduce yourself by sharing your name, professional title, if applicable, and country. Also, you can post your questions and comments at any time during the presentations. Our moderation team will be actively monitoring the chat and will bring your questions forward during the discussion segment. For those joining a TORC session for the first time, the Operating Room Global is a multidisciplinary professional platform representing over 260,000 surgical and preoperative professionals across more than 110 countries, making it the largest global network of operating room professionals worldwide. TORC brings together 42 healthcare disciplines and specialties currently and operates as a not-for-profit and non-governmental organization founded in Nigeria in August 2015. Today, TORC has over 20 active chapters globally, including representation across 31 African countries. Our mission is to advance surgical and preoperative care through education, research, advocacy, innovation, and capacity building with a strong focus on safety, equity, and system strengthening. TORC is an internationally accredited continuing professional development provider recognized by the CPD Group, underscoring the quality and global relevance of our educational activities, and is supported by its academic and innovation arm, the Operating Room Global Center for Education, Research, and Innovation, incorporated in Ireland, which leads our global agenda in education, research, innovation, and partnership. Our affiliated journal, the Operating Room Global Journal, is an open access peer-reviewed international journal inaugurated in May 2025, providing a platform for high equality evidence that informs practice and policy worldwide. TORC is also proud to host its own institutional review board, officially registered with the U.S. Office for Human Research Protections, reinforcing our commitment to ethical, responsible, and globally credible research. TORC is driven by a volunteer-led leadership model powered by passionate professionals who contribute their time, expertise, and vision to strengthen global surgical care. We're actively engaged with global alliance, including the G4 Alliance, Intersurgeon, and are listed with the Union of International Associations, UIE, and the Global Civil Society Database, reflecting our global accountability and reach. Once again, thank you so much for joining us today.
So, it is my pleasure to introduce Dr. Mugeni Inglide, a medical doctor and a general surgery resident currently pursuing Master of Medicine at the African Health Science University in Rwanda. Dr. Inglide holds a Bachelor of Medicine and a Bachelor of Surgery from the Zhejiang University, China, and is a certified data science professional through the African Leadership Exchange. She brings a unique blend of the clinical surgical training and data-driven healthcare insight with a strong interest in the global health informatics and the surgical research. She is a Torch Global Research Fellow and an active member of both the Rwanda Medical and the Dental Council and the Rwanda Medical Association. Beyond her clinical work, Dr. Inglide serves as the health coordinator and communication manager at the Action pour le Développement du Peuple, which is ADEPE, where she leads health program coordination, data management, and strategic communication. She also serves as the president of the board of directors at the ADEPE, contributing to community health, development, and the organization leadership. Her research capacity has been further strengthened through the intermediate operational research training and collaboration with the University of Global Health Equity and Partners in Health. Dr. Inglide has a strong professional focus on clinical decision making, patient safety, and optimizing surgical outcomes, particularly within the diverse and resource constrained settings. We're delighted to welcome you, Dr. Mugeni Kirezi Inglide, to this session where she will be speaking on the clinical decision making on the general surgery, balancing risk, timing, and outcome. We welcome you.
Thank you, Aditya. Like you presented, Dr. Mugeni Kirezi Inglide, and currently I'm greeting everyone either morning, afternoon, and evening. Right now I'm in Rwanda, and we are evening at 7 p.m. So I'm happy to be here, and I welcome everyone who took their time, their free time, to join us in this conversation, in this webinar. So without taking much time, let me start. Let me start by sharing the document. Give me some moment. All right, can everyone see my screen? Can a shared screen be visible to everyone?
Yes, ma'am.
All right, that's good. Like we all know that the good topic for me to dive in. Seeing together the balancing risk, timing, and outcome. So, sorry, the outline of today, we'll be seeing an introduction, the global data, as well as our regional data, balancing risk, timing, outcomes, and some of the references with some questions. We end up with questions and answers as well. So, as an introduction, we know that clinical decision making in general surgery is an intricate balance between patients and anticipated long-term quality of life. So this guide and expanded all right. Expand on the data-driven framework needed for an international audience, integrating a localized lens on healthcare infrastructure, experience development in Rwanda alongside generalized medical priorities. All right. So globally, the surgery is now recognized as a critical pillar of global health. However, the volume and the complexity present significant decision-making challenge. So we see that around 310 million. Any problem? We can mute probably those are. Yeah. All right. Continuing. So we're saying that around 310 million we do see them as a major surgical procedures performed worldwide annually, and 5 billion people lack access to safe and timely surgical care globally. And the mortality, we do see that the post-operative mortality is the third leading cause of death worldwide. So being ranked the third refer to the death within the 30 days of surgery globally, which account for approximately 4.2 million deaths annually. Looking into our local, I couldn't pass by without mentioning Rwanda. Rwanda Surgical Evolution, where it started to serve as a prominent global model for scaling up surgical care in a low and middle income country setting, and this decentralization and the non-surgical oriented part, where through its national surgical and obstetric and anesthesia plan, called NSOP, Rwanda has systematically shifted surgical care from centralized teaching hospital to regional district hospitals. As the workforce multiply, the collaboration with international bodies have drastically multiplied the chances of surgeon, anesthesiologist, and obstetrician as well. So we do have the 3 delay framework, where Rwanda health policy focuses directly on tackling the classic global surgical bottlenecks, like a delay in seeking care, where we have the community awareness and financial protection via our insurance, local insurance called Mutuelle de Santé. And we also have there is also a framework called the delay in reaching a facility. So that also have that's what we want to prove, that geographically terrain and the referral infrastructures, where is if we know that the surgery, the more you delay to reach any facility to have a immediate attention, that's the higher the chance incident to have the mortality. So as well, there is this framework, it has the delay in receiving adequate care. So we also, since our country, Rwanda has established in district hospital, where they have to have all settings related to surgery and surgeons as well, and have resources allocated to those district hospital to have availability to nearest population. Basically, that is a short of the Rwanda surgical evolution so far. And diving deep, we are going to see the first pillar, where for the risk assessment. So this is moving beyond intuition to data-driven stratification, where this is defined as the high-risk patent, where the more than 5% predict the mortality threshold, where here we have to know that surgeon must discuss not just the cure, but the potential for a functional survival and institutionalized survival. Is the standardized stratification. The SA physical status is a scale from 1 to healthy, to V, which is moribund, patient not expected to survive without the surgery. That remain a powerful baseline predictor of operative risks. So looking with PIPOSOM and the ACS and CQIP, where there is the risk calculator. That's how we calculate. So we show that the physiological and operative severe score for the enumeration of mortality and the morbidity. So using 12 physiological and 6 operative parameter to estimate exact risk percentage. So the American College of Surgeons, where they provide highly tailored and data-driven complication analytics. And here the frailty index, where with clinical frailty scale, where to quantify, here to quantify the frailty over the chronological age as a critical. So it showed that a high frailty index independently predict a greater likelihood post-operative failure to rescue where it has to be prolonged, it can be prolonged hospital stay and loss of independence. In short, I wanted to that we know about the functional survival and the institutionalized survival. So this functional survival is a gold standard of surgical success. So it refers to an outcome where the patient return to their baseline independence and preoperative quality of life. So here we focus to restoring the ability to perform daily activity, and to return to work after the surgery. So here the decision is made when we use shared decision making, which is usually an outcome the patient is hoping for a survival that allow them to live, not just exist, which is different compared with the institutionalized survival, where these represent just a technical success, but me that to those who had also who have to keep taking the dependent after the surgery, although the surgery has been successful, but they will have the dependence that will require them a highly medical support. And in our law settings here, law of, in the African countries where some of the medication can be quite expensive to some insurances, which could really be a burden to some of the patients that we face in our daily lives. So here, the decision metric for many, especially when considering the threat index, this outcome may be viewed as a complication, which is worse than death. So it is the outcome we try to predict and avoid through honest, shared, and decision making. As you keep seeing that decision making is always have to be the key focus for our approach in during the surgery. As well, here we come up with as well AI and machine learning in prediction. So while we currently rely on a validated score like PeopleSum to identify our high risk 5%, these are statistic number. So the future is we already in AI system. The future and what we are seeing in surgical informatics is the use of machine learning. We have to start to use the machine learning to monitor patients in real time. And it's not about replacing the surgeon or gut feeling, but augmenting it. AI can flag a patient for failure to rescue hour before they crash, allowing for the senior-led intervention that is so critical to survival. That's where we have to be using the real-time data to predict the failure to rescue, which potentially reduced to 2.8% mortality rate, which has been seen in a patient with complication. And as well, the transitioning from static pre-operative score to dynamic intraoperative and ICU monitoring. As you know, the AI or machine learning will be a safety net using algorithm to detect psychological trending before human recognition. So the value of time, our pillar 2 is a value of time. In emergency general surgery, timing is the most modifiable factor influencing outcome. We have our window of opportunities where the delay in necessary operative intervention are independently tied to severe escalation in complication, tissue necrosis, sepsis, which can lead as well to systemic inflammatory response syndrome. So, and the odd ratio for this one, which will read to 8.2 hours at least, the least, in emergency general surgery, missing the definitive window of opportunity to increase our odd ratio of in hospital mortality to 1.56, alongside profound inflation of critical costs. So overnight operating, which have shown that 3.1 times mortality risk that might occur due to the diminished overnight hospital staffing and fatigue profile. So it is those who work at the hospital know that the night shift where like the staff are tired for the whole day shift and leading to the evening surgeries that can occur, which are the emergency general surgeries. These have shown that 3.1 times has been had a mortality risk that has been seen during the data. So here I'm trying to show you the urgency tiers where we have the immediate resuscitative, and we have the urgent one, and we have the expedited one. So the clinical scenario, most of the time that we do see, the free rupture, the catastrophic hemorrhage, the compromised airway. This has to be, we have to target them. The targeted time has to be in less than 1 hour. While for the urgent one, we have the acute appendicitis, incarcerated hernia without the strangulation, but because the strangulation itself also is an emergency general surgery. So here with the urgent one, it have to be more less than 6 hours. And the expedited one, which can be edible obstructions and stable cholecystitis, can be less than 24 hours, no more than 24 hours, because if you get more than 24 hours, that's where we are starting to have the high risk mortality to that person and to lead them into the institutional survival mode. So here I was trying to show the urgency and the mortality rate, where it showed that elective surgery, the mortality is just 0.5, because we know the patient are usually stable, and the surgery it's programmed, it's planned. Definitely the mortality, it will be lesser likely. And for the emergency general surgery, we do see around 4% mortality. And where with the emergency general surgery with more than 72-hour delay, especially in our low-income countries, where you have to travel from a village to go to a high setting that where they can perform, where you can find a surgeon. It can take time, the period, the roads, the problem of ambulance, all that, which the patient might reach to the right facility, delaying more than 72 hours, which leads us to 8.5% mortality. And so together we're trying to focus so that we can at least reduce this delay, and by setting more hospitals and making the roads better, so that the patient can reach to the targeted facilities on time. So the damage control, which this control surgery, the principle, we have physiological limits, when to stop a definitive repair to save a life. So, and we also have the vicious cycle, halting the progress of metabolic acidosis, the hypothermia, and coagulopathy. So here we have to know damage control is about knowing when to stop. Instead of the 5-hour definitive repair on an unstable patient, we perform an abbreviated laparotomy to control bleeding and contamination. We then move to the ICU to correct their temperature and coagulation before returning to the OR for the final fix. So this is a critical decision-making shift, prioritizing physiological over anatomy. This is what the damage control surgery principles that we have to look forward to. For the outcome landscape, we, as our pillar 3, we have a complication-based outcome. So for the failure to rescue, where though here it doesn't show the way of saying it, the clinical risk assessment dashboard improving quality and safety in healthcare, where for the infection control, adverse event, medicine management, and the way to be care to a patient, ward administration, patient experience, risk assessment, and for those with comorbidities. All those depend on how the complication and the outcome for the patient. So for the International Surgical Outcome Study, it highlights that the difference in hospital mortality is often not the complication rate, but the failure to rescue. So 16.8% complication rate in elective surgery and 2.8 mortality among those with complication. So here we advocate that early recognition and senior-led intervention are the key to lowering failure to rescue. Well, augmenting surgical judgment, we do see the tools here of clinical decision support software, which combine predictive risk modeling with outcome tracking to support bedside judgment. As well, we have to be transparent. So surgeons prioritize visual risk depiction and transparent factors, waiting to build trust and enhance communication. With the integration, where we have successfully implemented this required integration into the surgical workflow rather than adding administrative burden. For the international outcome disparity, we do see that the outcome, especially the maternal mortality, especially for the C-section one, in the high income country, we have 1 in 10,000, while in low or middle income countries, there is 1 in 200, which show a big difference. But we're hoping that also will be improving in coming future years, that we'll be having fewer numbers, mortality in a mother who's giving birth. So the risk ratio is 50 times higher. While for surgical site infection is in high income, we do see that there is 4.2, while still in low middle income, we still have 10.8%. That show 2.6 times higher. And another one that's mostly shown cases is the post-esophagectomy mortality, which show 3.7% according to Global Surgery Cooperative and Lancet Commission on Global Surgery, and 9.4% in low and middle income countries. So safe surgical access, we do have in high income, it's more than 90%, while for low and middle income, it is less than 10%, which show a significant gap between the high income and the low income. But we are both, or the whole world are really working hard to reduce this gap so that we can have a good standard for the population, for our society as well. Dogma like NPO after midnight by using to the trauma of surgery. This is particularly vital in our elective cases, where our goal is to lower that 16.8% complication rate. So when we optimize the patient before the first incision, we significantly improve their trajectory toward a full recovery. So as we all know, that ERAS protocol, most of it is the new protocol that we are all following, where we have reducing the surgical stress with a multimodal pathway designed to maintain preoperative organ function. And the key pillar is the preoperative carbohydrate loading, minimal invasive techniques, and early postoperative mobilization. And the outcome we all want is the shortening of hospital stay and to reduce that complication rate of 16.8 for the elective cases. So shared decision making. Here we do see that clinical decision making isn't just about the data in the risk matrix. So it is about the person sitting in front of us, the patient, the caretaker, the caregiver. So those are the people whom we have to share those data in the risk matrix. When a patient faces a high risk procedure, we must ask, what does a good outcome look like to them? For some, it's being able to walk again. For others, it's simply being pain-free. So shared decision making ensures that if we take a patient to the OR, the patient outcome landscape matches their personal goal. So that's why it's really good before we do any surgery, any operation to a patient. We need that one-on-one talk with the patient so that we know what their anticipation are. So a defining success that's aligned with surgical outcome with the patient value and the high risk conversation. It is crucial for patients hitting the more than 5% mortality threshold. So with the resource allocation ethic in low middle income countries, so here we do see that like in a setting like in Rwanda, our decision making extend beyond the individual to the health system itself. So we must decide how to distribute our workforce multipliers effectively through the, and so we have shifted care to district hospital to tackle the 3 delay, and the ethical challenge is ensuring that the patient in a rural setting receives the same high standard, the safe surgical access as someone in a capital city, despite the significant gap we still face. So that's what I was telling, that the equity challenge, we have to be balancing the need for the mass access with the high intensity specialized surgery. So with the district versus the teaching hospitals, where we have to follow the NSOP and to maximize the value. So prioritizing the intervention that offer the greatest community benefit within the resource constraint. So the standardizing quality, we have the 4-hour standard. So every high risk patient should have their risk of morbidity and mortality assessed by the senior surgeon within the 4 hours of admission, rated to antimicrobial within 1 hour, the investigation done, report within 1 hour, and multidisciplinary involvement as well. As we know, surgery here require the surgeon, the anesthesia team, the nursing team, the whole team have to be involved so that the patient gets a required care and a proper investigation as well. So as we go to our ends, where we see the summary and our overtake away of today. So we do see that our objective risk is from move from gut feeling to validate risk score, as you see from ASA and the POSAM, to identify the 5%, the more than 5% high mortality group, so that once we categorize them, we know how to approach them and we know what we can do and how we have to approach them in a significant timing. So as well, the time in surgery is the most important and the most accurate that we have to focus on, where we have to prioritize the emergency general surgery throughputs to avoid mortality escalation associated with the delay of more than 24 hours to 72 hours. And the global standard, reducing global surgical mortality, as you now know that it is the third leading cause of death. So we require infrastructure for safe, timely, and data-supported surgical care in all income settings. So these were my references, and thank you. The questions are welcoming, and that's all we have to round up. Thank you so much for your attention and attentiveness. Thank you. Any question?
Thank you so much for the insightful presentation. We will take the questions at the end of our second presentation. Back to you there, Shruti.
Yeah, thank you so much, Doctor, for your amazing presentation. It was really insightful for us to hear from you. And let's go ahead with our next speaker. We have gotten a doctor. It is a pleasure to introduce Dr. Iman Khaled Abejalas Osman, a medical doctor and a global surgery advocate with a strong commitment to advancing surgical care and research across diverse settings. Dr. Osman holds an MBBS from University of Medical Sciences and Technology, Sudan, and completed her clinical training across Tanzania following her displacement during 2023 Sudan conflict. Her graduation thesis on tracheostomy outcomes at Muhimbili National Hospital was shortlisted for the UMST MD Prize for Best Overall Graduation Thesis in 2026, reflecting her yearly academic excellence and research impact. He is currently president of Incision Sudan and director of research for Incision, where the overseas global surgery research initiatives and contributes to strengthening student-led surgical networks worldwide. He has also She also contributes to World Health Organization Acute Care Action Network Secretariat, supporting advocacy and global efforts in acute care systems. Dr. Usman is a Tall Global Research Fellow 2025-2020 and as a Search Hub ambassador with the Global Surgical Foundation. Her work reflects a strong interest in patient safety, early recognition of clinical deterioration, and improving surgical outcomes, particularly from the perspective of early career clinicians working in dynamic and resource variable environments. We are delighted to have Dr. Iman Osman to the session. We shall be speaking on recognizing and escalating deterioration in surgical patients, a junior doctor's perspective. Please go ahead, Doctor.
Thank you so much for the wonderful introduction. Thank you again for this wonderful opportunity as well. I'm so excited to be speaking to you all today. You know, as we always say, good evening, good morning, and good afternoon to you all, wherever you are. And thank you very much for joining us. I want to start off with looking at a number, as you can see on the screen, a number that really forces us to pause and reflect on our daily practice. Studies across global healthcare systems consistently show that up to 80% of acute in-hospital deteriorations, the kind that lead to sudden crises like cardiac arrest or sudden middle-of-the-night ICU transfers, are actually preceded by trackable, documented changes in the patient's physiology hours before the actual crash. Let that sink in for a second. This means that the vast majority of cases, the human body is actively sending out warning signals. The data is almost always there. It's written down on a paper chart or noticed at the bedside long before things actually go wrong. So when a patient crashes, failure to rescue isn't usually a failure of data collection. It's a failure of translation and a breakdown in how the data is interpreted and acted upon. As junior doctors practicing on busy, overwhelmed wards, we live in that gap every single day. The reality of our frontline practice is very different from, idealized textbook scenarios and very different from high-income countries. We're often managing dozens of complex post-op patients at the same time. And the reality is continuous digital monitors are a massive luxury in the resource-limited settings that a lot of us work in. And it's something that we only have available typically for the sickest patients in an HDU or in a very tight HDU space. For the rest of the ward, their safety net is not a machine. It's simply our judgment. We're constantly running around trying to balance a massive, exhausting task list with the need to keep a very sharp clinical eye. So today, I want to talk to you about all of this from a junior doctor's perspective, how we can actually navigate this reality and how to use our raw senses to catch these changes early when there are no machine alarms, and how to communicate the urgency up the strict surgical hierarchy when everything gets chaotic. To understand, first of all, why deterioration gets missed, we have to look at the daily reality of a junior doctor's workload. I call this the junior dilemma, that constant, exhausting tug of war between running daily tasks and maintaining actual clinical vigilance. When you step onto a heavy ward shift, your brain is completely consumed by checking boxes. Your to-do list is endless. Did, the morning labs come back for the patient in bed 3? Are the consent forms ready for tomorrow's theater list? Have I finished writing all the discharge files so we can finally get some more beds for all the emergency admissions? When you're under all of this mountain of paperwork, administrative tasks, and technical protocols, your situational awareness definitely takes a massive hit. Cognitive overload is a serious danger. It's impossible. You're running around from bed to bed trying to finish tasks before a specific deadline, and ultimately you will naturally develop a bit of a tunnel vision. And honestly, we've all been there. It's incredibly easy to walk past an unmonitored bed, look at the patient and see that their eyes are open or that they're lying quietly under a blanket, and then you assume that they're fine and move on to the next task or patient. But there's something that we need to remember. Post-op surgical patients are highly dynamic. Their state can shift completely in a matter of hours. A patient who looks completely stable in the morning can be in early shock by the afternoon. And so we have to train ourselves to consciously step back from the task runner mindset. We have to remember that our primary job on the floor is not just finishing and catching up on all the paperwork, but we're also the continuous clinical radar for everyone on that ward. If our radar shuts down because we're too distracted filling out the files, the patient's primary safety net disappears entirely. Since we cannot really hook up every bed to a monitor as much as we would love to, we have to rely heavily on our physical assessment skills. In surgery, clinical deterioration is, I kind of covered earlier, it rarely announces itself with a sudden crash out of nowhere. The physiology whispers a lot longer before it shouts. And as frontline clinicians, we need to understand and remember exactly what those whispers sound like. Let's talk about the first and sadly most ignored warning sign, the respiratory rate. On a chaotic ward, when vitals are being done, the respiratory rate is almost always the one that gets skipped. Or, if we're being honest, guessed and written down as 16 or 18 just by habit on the chart. But in reality, tachypnea is the single most sensitive, earliest predictor of systemic trouble, whether that's occult post-bleeding, third space fluid shifts, or even early sepsis. Just before the heart spikes and hours before the blood pressure drops, the respiratory rate creeps up because the body is it's desperately trying to compensate for the hypoperfusion or the metabolic acidosis. So if you notice a post-op laparotomy patient's respiratory rate creeping up from 16 to 24 over a few hours, don't write it off as anxiety or pain. The body is trying to tell you something. The second major shift is mental status. We've all seen this and we've all been here. A post-op patient becomes acutely confused, agitated, or starts hallucinating and calling out randomly. On a busy ward, it's very easy to say, this is just anesthesia hangover or standard intensive care delirium. But altered mental status typically means that the brain is reacting to a drop in perfusion or a mounting systemic infection. And there's a counterintuitive trap that we fall into here. The patient who has been highly vocal and confused, calling out randomly for hours, suddenly goes quiet, and in an overwhelmed ward, you think, wow, sigh of relief. The patient has finally rested, is finally able to have some rest after the exhausting, time that he's had post-op. But you need to actually walk over to that bed immediately. The sudden silence usually means that the patient has completely run out of energy and they're sliding from a state of agitation to complete unconsciousness. Finally, you have to track the fluid balance manually. In general surgery, a dry and urine bag is definitely, your absolute best warding system. If a urine output drops below 0.5 milliliters per kilo per hour, the kidneys are typically flagging a major perfusion crisis. They're actively shutting down urine production to conserve volume for the heart and the brain. This typically happens hours before the blood pressure changes on a manual cuff, which is something that a lot of us typically rely on. So unfortunately, if you're waiting for the low blood pressure reading to tell you that your patient is in shock, you're not catching it early enough. You're already way too late. Once you recognize that a patient's trajectory is changing, the natural next step would be immediate escalation. But this is exactly where human psychology works against us on a busy ward, causing the system to hesitate a little bit. I like to call this the bystander effect. We typically talk about the bystander effect in, regards to like the public and being on a pavement. That's the example that's always given. But even here, it leads to a dangerous phenomenon known as the diffusion of responsibility. Think about, how a surgical ward operates in real life, whether that's this morning or a few months ago. A post-op patient is never isolated. They're surrounded by a large, highly competent multidisciplinary team. Over 24 hours, they get seen by consultants in the morning, registrars checking in between theaters, junior residents changing fluids, nurses giving medications, and the physio team getting them moving. Because there are so many brilliant eyes that are technically hovering around in the environment, responsibility will naturally start to split and diffuse. The ward nurse might notice the rising pulse, but assume that the medical team already noted it during the morning ward rounds, and they must have a plan. The junior doctor might see the drop in the urine bag, but assume that the nursing staff or that the previous shift have already flagged it to the registrar. Everyone assumes someone else is tracking the trend and holding the collective worry. That's the bystander effect. When everyone is focusing on their individual checklist or their specific shift tasks, the big picture will sometimes get completely dropped. So as junior doctors, we really need to break this psychological trap. We can't afford to assume that someone else has already noticed the trend. And if you see it, you have to be the one to point it out. But breaking that silence brings us to the biggest, most unspoken barrier of the floor: imposter syndrome and the hierarchy of hesitation. Again, let's be completely honest with ourselves. The reason we hesitate to escalate deteriorating patients usually isn't because we don't know the signs. We don't miss the signs. We've spent thousands of hours studying, we've passed grueling medical exams, read all the textbooks, and we know exactly what a patient slipping into sepsis or hypovolemic shock looks like. The knowledge is fully there. The bottleneck happens when we try to speak that knowledge upward into a strict surgical hierarchy. When you notice a subtle trend change, like for example, a creeping heart rate or a slight change in behavior in a post-op patient, this agonizing internal monologue starts to take over. You'll start to think the senior registrar is currently, for example, scrubbed in theater doing an operation, a major operation, high stakes. If I interrupt them to call them reporting a creeping pulse, am I going to look foolish? Am I missing something totally obvious that a better doctor would know? What if they think that I won't be able to handle patients or the ward floor on my own? Because we are juniors, we constantly second guess our clinical judgment. We suffer from this intense imposter syndrome where we assume that because our seniors know, of course, infinitely more than we do, they must have a magical, invisible handle on the situation from afar. We assume a lot of the time that if it were a real emergency, someone more senior would have already figured it out. But we fundamentally have to rewrite how we view our position and our place on the team. Our senior registrars and consultants have immense clinical wisdom, but they cannot see what they're not standing in front of. They're trapped in operating rooms, managing outpatient clinics that are usually full of patients, and probably a lot of the time handling administrative or system-wide crises. They don't have the eyes on the ward at 2 a.m. and the half an hour to spend with each patient one-to-one like we do. Having imposter syndrome doesn't change the fact that you will be the one who spends the most time with the patient at bedside. Of course, seniors will always have the ultimate answers, but you're the one who actually holds the fresh and real-time data. Escalating a worry isn't pretending to know everything. It's you doing your job by delivering the objective frontline data that your seniors actually need to be able to make that final call. Your worry is a very valid piece of diagnostic data, and you should never let, the fear of looking foolish silence that instinct. To ground this concept of imposter syndrome in a real-world environment, let me share a reflection of a patient that I came across in one of my earlier surgical rotations. We were covering an unmonitored bed in the surgical ward where a patient was recovering from a major abdominal procedure. The ward, as it is in all of the resource-limited countries that I've worked in, very, very overwhelmed. We're always, short-staffed, and we're managing a massive task list of missing labs and paperwork to fill in, pre-op files, administrative discharge, so many things. Around midday, I walked past the patient's bed and I looked at his output, like his urine output bag, and I realized that it had dried up significantly. It dropped to, I think it was just under 15 milliliters per hour, basically. His urine bag, for those who've had the experience, that literally means it's practically empty. And my textbook knowledge instantly was like, okay, there's clearly a problem here. I knew that oliguria in a post-op general surgery patient is a classic early warning sign of third space fluid shift, or probably that this person is going into early sepsis. But when I looked at the patient, he was lying quietly and I checked his blood pressure. It was completely stable and he wasn't complaining of severe pain. I was supposed to call the registrar, but I picked up my phone and I couldn't do that. I knew he was currently scrubbed in theater and he was dealing with an emergency case, and this hierarchy of hesitation took over. His blood pressure is perfect. He looks comfortable. If I interrupt a senior surgeon who's actively operating to report a dry urine bag, he's probably going to think that I'm foolish. It just made me think, am I really missing a piece of information or a piece of the plan that a more experienced doctor would already know? Because I was still very junior and I was navigating a very busy system, I second-guessed my very own clinical senses. I told myself I would just wait and check on the bag again in the next round so I could finish chasing the missing lab results, which, as we know, is a complete nightmare. By the evening, the patient's mechanisms had completely exhausted themselves. His blood pressure had crashed, and he went into acute kidney injury secondary to a severe systemic infection. He was stabilized, thankfully, but that shift completely redefined how I view my role on the ward. I didn't miss the sign. I had seen it, and I knew exactly what an empty urine bag meant. So the breakdown was not a lack of medical knowledge, but it was a temporary lack of confidence to speak up across the hierarchy. It really taught me that, as junior doctors, we can't wait for a patient to look dramatic or for their blood pressure to crash before we speak. Our clinical worry, backed by our eyes on the floor, is very crucial data. We need to have the courage to communicate it because waiting for a sign to become obvious carries a very real cost. So because I lived through this eternal hesitation, I realized that we need a communication tool that completely strips that fear and anxiety and, the over politeness out of the conversation. On an overwhelmed ward, you're constantly asking our other junior doctors and colleagues for help and, support with smaller kind of tasks. And if you use that same casual tone in a clinical crisis, the senior team is not going to match your urgency. So that is why we mastered the SBAR framework. It's literally a lifesaver for a junior doctor. It replaces hesitation with this like very unignorable and structured clinical facts. Think about the difference in, calling a senior registrar and saying, I'm so sorry to bother you, but the patient in bed 4 looks a bit unwell and his vitals are a bit off and he's acting a little bit strange and maybe you could look at him whenever, you're done with theater. Let's be honest, guys, come on. This communicates zero urgency and it sounds like a casual favor, something that, wouldn't really be taken seriously. But you need to lay out structured data. So first of all, you give the situation. This is Dr. Osman, for example, in the surgical HDU, and I have an acute clinical deterioration in bed 4. And then you give the background. He's a 65-year-old male post-op day 2 from an open laparotomy with a perforated bowel. Then you give the assessment. Over the last 3 hours, his respiratory rate has climbed from 18 to 28. His heart rate is sustained at 115, and his urine output has dropped over the last 2 hours to below 15. And he is now acutely confused and agitated. Then, your clinical assessment. So what do you think? Maybe my clinical assessment is that he's developing early septic shock. Finally, your recommendation. I need an immediate senior bedside review within the next 15 minutes to decide on a relaparotomy or an escalated fluid resuscitation program. So you can kind of see what this framework does. It strips away all of the emotion and the hesitation. It doesn't sound like you're a nervous junior asking for a favor anymore. It sounds like a professional clinician launching a critical trigger that simply cannot be ignored. It leaves the senior doctor with a clear clinical picture and a very clear demand. The SBAR framework really bridges that hierarchy gap and instantly kind of helps override it because structure always overrides the status. So from a junior doctor's perspective, recognizing and escalating a deteriorated patient on an overwhelmed ward is a deeply active manual skill. We can't sit back and wait for technology or continuous monitors or maybe automated alarms as much as we'd love to, but in our settings, we can't wait for them to come looking for us. But we absolutely cannot let a lack of confidence, imposter syndrome, or a divided team keep us quiet, because mastering the basic physical exam by actually tracking those respiratory rates yourself, physically checking the urine bags, noting the subtle mental, awareness or consciousness shifts, and actually measuring the heart rate every single time. By doing all of these, we catch the whispers long before they turn into catastrophes. And once again, using the clear and structured SBAR communication framework, it just means that our frontline data is actually heard and acted upon across the hierarchy. We are absolutely the frontline defense for our patients, and our vigilance is what brings them safely throughout their surgical journey. Thank you so much for your time tonight, and I would love to hear any thoughts or reflections.
Thank you, Dr. Mugeni, Kirezi, for your excellent presentation on clinical decision-making in general surgery, specifically balancing risk, timing, and outcomes. And thank you, Dr. Iman, Osman, for the valuable insight on recognizing and escalating deterioration in surgical patients. My name is Emmanuel Tuishimire, and I will be leading you through the Q&A segment. For our first question is from Dufitumukiza Fred, and it is for Dr. Kirezi. What can be high risk for using artificial intelligence in surgery, and what can we expect in the future about the artificial intelligence? Thank you. Dr. Kirezi, I think the question is for you. Can you hear me? Can you hear my voice? Okay, thank you. We will proceed to the next question. I think Dr. Kirezi might be having some internet issues. The next question is from Mohammed, which is also for Dr. Ingrid. How do you share the decision making? How do you do shared decision making when the patient is unconscious or have no family present? So I think Dr. Ingrid is not, we lost him. If Dr. Osman can answer the question, we would be more appreciating for her to step in and answer the question. Thank you.
I think, an unconscious patient is definitely one of the harder kind of interactions that you come across in a surgical ward, especially, as said, when there is no family present. But I do believe that, different hospitals have certain protocols to follow in this, in such cases. And we do recognize the unfortunate reality that it does happen a lot, especially when you have trauma cases or patients that come into the emergency room. From a junior doctor's perspective for this is really one of, those instances where you listen to your seniors, you ask, the questions and see how they would handle it. But I think Dr. Mugeni is back, if she could answer this from a more senior point of view.
We can see Dr. Ingrid is back. The question was was from Fred, which was asking about how do you do a shared decision making when the patient is unconscious or when the patient has no family present? How do you do shared decision making? Thank you.
All right, that's a good question. And for in that particular case, when there is no, we do see them at emergency, especially trauma, accident, where the patient will come without any caretaker, no even ID, no national ID, no insurance. Like the patient doesn't have any document with by themselves, and you have to approach the patient. So that is an ethical approach that we need to do. So in that case, what we do, the decision is made with the multidisciplinary, and you have to inform the administration. Yeah, the administration to know that there is this kind of patient, a non-patient who is in our hospital, and then once the administration acknowledge the patient, then we proceed with our management accordingly. So that's how we can approach this kind of patients who doesn't have any caregivers. Thank you.
So much, Dr. Mugeni, for breaking it down. Here is another question for you. It is from Dufitumukiza Fred. He is asking what can be a high risks of artificial intelligence in surgery and what can we expect in the future about the artificial intelligence?
Sure. Yes, like I said, artificial intelligence, and it's good that we can use them, especially for allowing us to track down the data and the algorithm as well. But though we all know that we are expecting them in our coming future. They have everything that comes have the good and the bad, the do's and the cons. So for the as AI being in a system, healthcare system, yes, it will be used. It can detect sometimes bias, especially it can be good for the high income. That's where they are being established. But once they reach in our setting, lower income, where we have different kind of anatomical variation and the nutritional status that are different, especially that we have in Africa, it's known that we have nutritional rich in fiber diets, and as well where our patients mostly present themselves with the late stage diseases. So here we do see that it might bring that bias in algorithm and misdiagnosis or even inappropriate surgical plans. So that is, I think, one will be quite complicated with the AI model in our system, in our healthcare system, as well as the skill atrophy. Though it is not going um to replace, because most of people think like AI will be replacing. No, it won't be replacing. It can be used as an aid, as to support. See, but with the under supervision of a surgeon. Like now we know that there is a robotic surgery that occur around the world, that someone from China can do it. He can do a surgery in America, or if someone in America can perform a surgery while the patient is in Africa, in Rwanda, for example. So that is a development of AI. So, but it doesn't mean that it is only the robot that is. It is that robot is being conducted with a surgeon. So that are the way that we face that might be that it can have any negativity, but the positivity is that it will be supporting us and helping us in our daily, especially in, for example, if I remember very well, in China they have started AI like monitoring. If you come in the hospital, it will take your vital signs. So that is a good start. Instead of you taking a long queue waiting for just taking the vital signs to start to, so that we can meet with your doctor. You already have it, the doctor will immediately have your data, your vital signs monitoring to their screen. So that is the only thing that we are expecting in the future. Otherwise, being AI itself replacing surgeon, that I believe that will not happen as we expect in our coming future. Thank you.
Exactly. Thank you so much, Dr. Kirezi, for that response. Our next question, I can see more questions coming in from the audience. The next question is for Dr. Iman. Thank you so much for the amazing presentation. And here is the question from Eramim. How can a junior doctor balance being concise with being complete with using SBAR, especially during the urgent deterioration where every minute matters? Thank you.
Thank you for the wonderful question. Yes, that's definitely a very important thing to note out. As you said, every minute matters. So using the SBAR framework, the whole purpose of it is to actually make sure that, you're being as concise as possible. I would say one of the, best kind of things or ways to go about this is to answer this different like segments of the SBIR in bullet points so that you're not speaking completely out of, memory or just kind of going on. And to find these bullet points and be able to identify maximum 3 points for each one of, the letters of the SBIR, probably refer back to the history that you've taken about the patient. So typically when we have an admission, you'll sit with the patient and you'll do a complete history and, all of the examinations and stuff. But at some point, you'll have to kind of give your summaries or write your summaries to like add to the patient's file or present on your ward rounds. So referring back to those is probably another, really helpful thing as well.
Thank you so much, Dr. Iman. I think that really answered the question clearly. So I would like to receive another question for Dr. Kirezi. It is from Ayan Sote. When shifting surgical priority from teaching to district hospitals, how did Rwanda achieve that with regards to the health workforce? Did you have to create new responsibilities for the existing workforce? Thank you.
Well, the system country Rwanda has brought is a Ministry of Health. It's 4x4 that we call 4x4, where they have initiated that innovation by implementing, bringing in more doctors in the system, so that because mostly there were only most of the doctors were in the teaching hospital, so to bring in the district hospital be involved in that in that implementation of 4x4, they had to bring more and I can say advocate so that most of the general practitioners doctors can be part of that 4x4, so they can specialize, so that they can start to work in those district hospitals. And really it has started to bring a good impact, where like the more they graduate, they immediately go to the district hospital. So I would say that they have created new responsibilities by bringing in many doctors into the system, so that we can have many doctors, specialized doctors into district hospitals, so that the communities at a lower grade they can have access easily to the district hospitals. Thank you.
Thank you so much, Doctor, for sharing such insightful answer. I can see that Belinda has raised the hand. So Ali, I would like to give him a mic. Please, you can unmute and ask your questions.
All right, thank you, Emmanuel. Good evening from Ghana.
Thank you.
And I
Thank you,
want to
Emmanuel.
thank you to our two presenters, Dr. Osman and Dr. Kirezi. I hope I got it right. Yes.
Yeah, yeah, yeah.
Emmanuel.
All
On
right.
behalf of Operating Global and the Global Education and Training Committee, I would like to sincerely thanks our respected speaker for their excellent presentations and all the participants for joining us from different country, different professional backgrounds and healthcare setting.
Hello, I haven't
Um,
finished with my submission.
yeah, yeah, sure. Am I
Can I go
am I
on?
audible to you? Yes, please.
Okay. So I was commending our two presenters for such a wonderful presentation, very timely. And my take for today is that in both presentations, one thing is clear, that we need to be working as a team, as healthcare professionals. We need to work as a team. In the first presentation, yes, it is clear that time is of essence. The earlier we put in our interventions, the better our patient survival, and for that matter, better outcomes. So with that said, I would like to ask Dr. Kirezi a question. She mentioned a 4-hour standard, and she said within that period, a senior surgeon is expected to see the patient. So if we are relating it to timing, as her presentation was, if it would take 4 hours for the surgeon to assess and then decide what way to go, then it means that by the time the actual intervention is happening, it is taking well over 6 hours, if I'm not
Sorry,
mistaken. So
please.
I just want to find out if the 4-hour standard is a globally accepted duration. Just a little clarification on that. And two, on Dr. Osman's presentation as well, I think that the dilemma that the junior doctors go through, we all go through it as professionals, especially from the nursing perspective as well. Sometimes the same courage to speak up, because we nurses are constantly with the patients. And if we monitor the patients 24 hours, so for a good decision to be made or for certain things to be picked up quickly, we
Sorry,
need to,
Belinda.
yes,
Hi, can you hear me?
yes, I can.
We are currently running out of time. Please, we would appreciate if you try to be as brief as possible.
Yes, so I just
As
want to say, yes, I'm rounding up. So my point is that the same confidence that affects them as junior doctors sometimes affects nurses as well. So this is to help us all support each other. Like I said from the beginning, to always work as a team. And I like the SBAR framework that she added to the presentation. Thank you.
yeah, thank you so much.
Thank you, Emmanuel, and thank you for your valuable insightful on behalf of the operating room global and the Global Education Training Committee. I would like to sincerely thank our speaker for their excellent sessions and all the participants joining us from the different country, professional backgrounds, and healthcare setting. We truly appreciate your commitment to continuous learning and to improving patient safety and peri-operative care within your local institutions and communities. Today's sessions once again highlighted the importance of collaboration, education, timely clinical decision making, and global knowledge sharing among operating room professionals. We encourage everyone to share the key lessons from today's webinar with your colleagues and team as a part of strengthening safe and effective surgical critical worldwide. Please stay connected with Talk through our upcoming webinar, educational programs, and research activities available on our official platforms and websites. So kindly remember that the evaluations and the certification form will available for 24 hours only after this session. Completion of the evaluation is mandatory to receive your TORC certificate, which will be issued within 5 to 7 working days and linked to your TORC membership ID. So once again, Thank you for the being part of the TORS global community. We wish you all a happy, productive, successful day and evening ahead. Thank you, and we look forward to meeting you again in the future TORS education session.